Thank you, everyone. Thank you, Halie, for for accepting our invitation. It is my pleasure to introduce today's speaker, Miss Halie May, a distinguished clinical genomic specialist and certified genetic counselor. A graduate of the prestigious Joan H. Marks from the graduate program in human genetics at Sarah Lawrence College. Halie began her career at Columbia University, Irving Medical Center in precision medicine research. Later, transitioning into the dynamic startup world, she currently serves as a clinical genomic specialist at Natera, where she continues to advocate for increased access to genetic testing and education. Halie is a passionate advocate for the profession, spearheading efforts to promote genetic counseling in New York State and pursuing a federal Medicare recognition for genetic counselors. In addition to her clinical expertise, Halie has published extensive in precision medicine and in actively involved in public policy. She currently chairs the New York State Genetic Task Force Public Policy Committee and has a remarkably ability to communicate complex scientific concepts, such as she acts as a lecturer, presenter, and technical writer too. Her leadership in grassroots and federal advocacy continues to broaden patient access and awareness. Please join me in welcoming Ms. Halie May, a leader in genetic counseling and genomic medicine. Welcome, Halie, and over to you. Yeah.
Thank you, Dr. Reddy. I appreciate the introduction and thank you for inviting me. Let me share my screen. Let's see. How does that look?
That's fantastic.
Perfect.
Yeah.
Okay, so at Dr. Reddy's suggestion, I am presenting on navigating variants of unknown significance in genetic counseling. And so as Dr. Reddy said, the beginning of my career was at Columbia University Medical Center in a research capacity. I was working as a genetic counselor on a whole exome sequencing study doing gene discovery. And so I found myself looking at the whole exome sequencing data from patients that maybe had genetic testing before, but were undiagnosed, and we were unable to figure out what the cause of their condition, in order to see if there were any specific variants or mutations that were in new genes that could be associated with disease. And so one of the papers that I had put out, for example, was on the SHANK1 gene, which was a new association with autism. We were able to put that gene onto GeneMatcher and identify other patients throughout the world internationally. We ended up finding 9 with loss of function variants. And so this was a good indication that this gene was most likely causing the patient's autism. And so I have a lot of experience in curating for rare disease, in justifying and then presenting that curation, and in classifying variants. And so where I'm starting today is really the journey of variant classification. So I'll be talking about how variants are classified into benign and pathogenic. And in that way, you'll see why variants that don't fall into the categories of benign or pathogenic fall into variants of unknown significance. And then at the end, we'll finally get to what that means in the clinical world, and what you can do with VUS is if they come up in your patient. So it all starts with the American College of Medical Genetics that came out with guidelines that were established in 2015. This was a joint consensus with the American College of Medical Genetics as well as the Association for Molecular Pathology. And these groups came together because in the decade before that, next generation sequencing had really just become much more efficient, and patients were able to get genomes and exomes sequenced much more easily. And so with this guideline, this was the first time that we were able to consistently curate genetic variants and classify them in a way that is uniform, so that patients would be getting back the same kind of classification and know whether something is disease causing or not, based on, again, these standard guidelines. So these have been updated over time, and at least in the US, these are the tried and true guidelines that laboratories use in order to classify variants. I believe that's probably the same for other countries as well. And that's what I'm going to be focusing on when I'm talking about how you actually utilize these guidelines to classify a variant into pathogenic or benign, and therefore into a variant of unknown significance. This is another standard and guideline that I wanted to at least throw out there. this does not have to do with variant classification, but this has to do with a standard nomenclature. So just like the ACMG guidelines that I will keep referring to is now the standard mechanism for classifying variants, HGVS, the Human Genome Variation Society, this is again another international society, holds the guidelines for terminology, essentially. So for example, before I was in school, probably a decade ago, mutation would have been the common word that you would use for genetic variation. That is now variant. This is HGVS has come out and said that this is because, of course, mutation has a negative connotation and it can sound like something that is demoralizing to people who have a genetic variant. And so instead of using that terminology, we're now using variant. Also, HGVS specifically recognizes ACMG guidelines as the way of classifying variants. So if you're putting out paper into the literature, you're gonna want to use the HVS nomenclature for different genes, and you're gonna want to classify as pathogenic, likely pathogenic, uncertain significance, likely benign, or benign. And these are the 5 classifications for variants that we get from ACMG that are now standardized. I know that when I was writing papers, I was constantly on HGVS to see and make sure that I was using the right name annotation for a gene, for example. Just as a quick personal example, I worked in cerebral palsy for a while as well. And so in writing a paper on a cerebral palsy cohort, I had a mentor that kept wanting to use the word spast for the spast gene, but really that was an old interpretation and an old nomenclature, and that's more of the name of the protein. And so using HGVS, I was sure that I should be using the actual gene name, which is SPG45. I want to say there's a lot of SPGs in that family, but this is why it could be so important to make sure that we're talking about the same genetic variant or gene in the same way. And so this is directly pulled from the 2015 ACMG paper talking about the standards and guidelines. These are the criteria that we're using to classify a genetic variant. So if we have whole exome sequencing, whole genome sequencing data from a patient and we have a variant and we say, this variant is interesting, we don't see it in the typical population and we wonder if it is causing this patient's disease. This even could be a gene that we don't even know that is associated with disease yet, and we can still try and classify the variant based on these criteria. And so the criteria are population data, computational data, functional data, segregation data, de novo data, allelic data, and then you can use some other databases as well. And so you will categorize that criteria on a scale of benign to pathogenic and assign it a score of a benign score, a benign strong score, a benign supporting score, a pathogenic supporting score, or moderate or strong or very strong, etc. And so you will literally assign it. If you wanted to assign this top left one, for example, this benign strong population data criteria, you would assign it a BS. And then at the end, it's almost like a math equation. You're essentially adding together all of the different classification scores. So if your variant gets a BS and 1 PM and 2 PSs, you'll say, okay, what is a BS strong plus a pathogenic moderate plus 2 pathogenic strong criteria? When you add them together, what classification does that equal? And so just to use a couple examples here, this benign strong, so we're now saying that this is a point for benign strong for variant classification. This one on the top left is saying this is if the allele frequency is too high. So if a variant is observed in controls in a high frequency, then we're not going to think that it's disease causing, so it's going to get a BS. While we can see this very strong on the opposite side under predictive and computational data. If it is a predicted loss of function variant in a gene where loss of function is a known mechanism of disease, that's automatically going to get this PVS1, which stands for pathogenic very strong score. Sorry, it is. I'm stumbling on my words. It is a little earlier. So I'm going to go through more of what each of these are so that you can understand what will make something pathogenic or benign before talking more about that VUS. And so this is just what I was saying before. If you assign a PVS1, PS1 to 4, PM1 to 6, PP1 to 5, you are assigning a score toward pathogenic or likely pathogenic. And if it's a BA, BS, BP 1 to 4 or 1 to 6, you're assigning a score that will be more likely to give it a benign or likely benign classification. So this is the very strong one. So imagine this is the one that is all the way on the right of that diagram that I just showed you. This on its own is enough to classify something as pathogenic, a score of PVS1. This is a very strong piece of criteria, and this is where I said this is a protein loss of function variant, meaning the protein no longer has its function. This is due to a nonsense, a frame shift, or a splice site variant, which are loss of function variants. And if it's a loss of function variant that impairs protein in a loss of function gene, this is PVS1, this is enough to be pathogenic. Things to think about here, when I was classifying variants, I would also often look at the PLI score. If you are looking at exact, for example, or what is now called NOMAD, it will actually, every gene has a PLI score. So a PLI is showing you the amount that that gene is tolerant to loss of function variation. A higher PLI score means that is more intolerant. So if it's a PLI of 1, for example, this is a ratio, and this is a ratio based on the number of loss of function variants that occur in the gene versus the number of loss of function variants that are expected to occur. And so a PLI of 1 would mean that there's not as much variation expected, so it is rare, which means that it's not conserved throughout time. So if a loss of function variation is not conserved throughout time in the evolution of the genome, that means that there is loss of function variation that is more likely to be disease causing, and it's more likely to be impacting protein in the gene. So you want to think about the PLI score. You want to think about the disease mechanism. Again, if it's a known loss of function mechanism for disease, great. That means that this will likely get a score of PVS1. If it's a gene where only missense variants, which is that one substitution letter change, is a known mechanism of disease, that's not a type of loss of function variant, so it may not be able to get this score. You want to think about what exon it's in, because if there is a variant in the very last exon of a gene, that means that the loss of function variant is less likely to impact the protein that that gene is coding because it's at the end. So literally by the time that that variant is coming in and affecting the protein, most of it has already been transcribed, so it may not be affecting the protein. So this may be a reason to not give it a score of PVS1. Are there other loss of function mutations in that region? I think that you would use this with every kind of variant. You want to see if there are surrounding variants that have already been called pathogenic or not. If so, we can assume this is a pathogenic region that is not very intolerant to loss of function variation, and it might get this score of PVS1. This is the strongest criteria again. The next these are 4 scores, PS1 to PS4 for pathogenic strong. These are strong evidence of pathogenicity. And again, we're adding these together. So it is totally possible for a variant to get a PVS1 and also a PS1 or any of these other scores toward pathogenic. So according to the PS1 evidence, it can be assigned a score of PS1 if there has been another variant at the same exact spot. So this would be a different nucleotide change that occurs that still results in the same amino acid change that has already been called pathogenic. This is a good indication that this is also pathogenic. PS2 is if the variant is de novo, so if it is not inherited by mom or dad, if it's random variation, this is something that's more likely to be pathogenic, especially if the proband is affected and has a condition and parents do not. That's a great reason to give this a score of a PS, a pathogenic strong indication. PS3, you may establish that score if there are functional studies that are proving the loss of function mechanism, lab studies. And PS4, you may give this if this has been reported before multiple times, I believe. These are PMs, so these are reasons to score the variant as a pathogenic moderate. Again, you could have a variant that has a couple of PS scores plus a PM. You could have a variant that has just a couple of PMs by itself, and then at the end, you will see what that equals as far as a final classification. So for PM1, these are protein domains that are known to be critical to protein function, where all missense variants are considered pathogenic and none are benign. So if this is a missense variant, that one letter change in an area where a lot of different missense changes are already pathogenic, that's called a hotspot region. That's a moderate piece of evidence toward pathogenic. Generally, and I think you can see this by now if you see where we're going, and especially if you're used to variant classification, it's more difficult to assign pathogenicity to a missense variant than to a loss of function variant. It's usually just not as clear how missense variants affect protein function. Pathogenic moderate is having to confirm that read depth is sufficient for an accurate call and needing to verify that the database is matched to each patient. So PM2, you're going to be looking at the population frequency, and if this variant is not in any controls, this is a reason to give it a score of moderate pathogenic to assign it a PM2. I suppose in this case, if it is absent from controls and if there is appropriate read depth, because it can also be absent from controls but just be a fluke or just be something that is like something that the sequencing picks up that is not necessarily accurate, like the dirty data. PM3 is saying that if this is a recessive disorder, it was detected in trans with a pathogenic variant. So if this is a variant and we know that there's a pathogenic variant on the other gene inherited from the other parent, then this is a good indication, especially if it's a phenotype match, that this is pathogenic, and this can be given a score of PM3. PM4 can be given if the protein length is changed due to in-frame deletions or stop loss variants. Interestingly, it was always interesting to me that stop loss variants are actually, there's less assurance that those are going to be pathogenic than a loss of function variant. So even a stop loss or a stop gain is just not as strong of a piece of evidence as a frame shift or another loss of function variant, such as a splice site. If there is a novel missense change where a different missense change has been determined to be pathogenic before, this may be a moderate piece of evidence. And if it's assumed de novo, but there's no confirmation, this would be a moderate piece of evidence. So if you remember on the last slide, I had said confirmed de novo could be a strong piece of evidence. If we don't have parent samples and we can't confirm that this is going to be de novo or that this is de novo, this is only a moderate piece of evidence because we don't have that confirmation. And then finally, there is supporting evidence. So segregation, if a variant segregates among multiple affected family members, even if the variant has never been seen before, this is still a piece of evidence. It's a supporting piece of evidence to pathogenicity. Number 2, a missense variant in a gene where there's not a lot of missense variation. This is called a Z-score, actually. So before, when I was talking about the PLI score, which is a ratio that's talking about the gene's intolerance to loss of function variation, the Z-score is able to tell you the intolerance to missense variation. This is also something that I used to look at in NOMAD, in that population database. If you're looking at that, the Z-score is there. PP3 is computational evidence, essentially. So these are algorithms, bioinformatic algorithms, that are trying to decide whether a specific variant has an impact on protein function. These are what you would call in silico algorithms, and I do have another slide on that. PP4, if the phenotype is very specific. So notice that this entire time I've talked about pathogenic very strong, pathogenic strong, pathogenic moderate. Notice that clinical information hasn't even come up yet. This has all been only evidenced by the variant information and variant data. This is the first time in supporting evidence that you actually see that the patient's family history could be accounted for when doing the classification. So a strong family history in this variant classification is actually only a supporting piece of evidence for pathogenicity. And then the last one is if a reputable source reports a variant as pathogenic. So for example, maybe another lab called a variant pathogenic. This is a reason that you could use this as a supporting piece of evidence for pathogenicity, since it's not something that you are seeing internally, but you're seeing it externally. In silico predictors, this is what I was talking about for PP3, computational evidence, are also called in silico predictors. So this is a supporting piece of evidence to classify a variant as pathogenic. So for the most part, in silico predictors are not as sensitive for missense variants, and they're more sensitive for splice variants and other loss of function variants. So if I'm looking at an in silico predictor and I'm trying to see if it's going to tell me and give support for whether a variant is going to impact protein function, I will consider it and weigh it a little bit more for splice variants, not necessarily as much for missense variants, because it's not as good as picking those up. Examples of splice variant in silico predictors would be TRAP scores and Gene Splicer. And then if you're seeing polyphen scores, SIFT scores, or mutation tasters, another piece of evidence, these are for missense variants. So these are moving on to benign. These are the benign pieces of evidence. I'm not going to go through each one of them, but I can tell you BA1, this was the one on the top left corner of that original diagram I showed you. This is the strongest piece of evidence for benign, and this is going to be a high allele frequency. So a frequency of over 5% in controls. These are control databases. And just like all of the pathogenic reasons we went through to classify a variant as pathogenic, these are other pieces of evidence for benign here. And then finally, this is the rule to combine them. So I've been saying you can have a PVS1 and a couple of PMs and a PS and see what that equation equals and what classification that gives you. This is where this comes in. This is the rules for combining them. So this is pathogenic at the top. So if you have this PVS1, I think I mistakenly said before that PVS1 is enough by itself to call something pathogenic. I suppose that's false, so I take that back. So this is a very strong, if you have PVS1, which is that loss of function variant in a loss of function intolerant gene, PLI of 1, as well as at least another strong piece of evidence, it can be pathogenic. Or a PVS1 and at least 2 pieces of moderate evidence, it can be pathogenic, or 1 PVS1 and 1 moderate and 1 supporting. So now you can kind of see how these add together to create the classification for the variant. So now finally, I've been talking about how to classify variants, what can make them pathogenic, what can make them benign. What is a variant of unknown significance? A variant of unknown significance is a variant that doesn't fall in either category. It doesn't have enough of this. It doesn't have enough very strong criteria to call it pathogenic or to call it likely pathogenic, and it doesn't have enough benign criteria to call it benign or likely benign. So where does it go if it doesn't fit? This is when it's called a VUS. There's not enough pathogenic evidence or benign evidence. If it does not fulfill this criteria, the variant defaults to uncertain significance. This is the direct quote from the guidelines. So essentially, what I tell patients when they get a variant of unknown significance is that a variant of unknown significance is a big question mark. It means that we don't know if it's causing disease or not. And it's usually because we don't have enough evidence, and that is often it. If we don't have enough evidence toward pathogenic or toward benign, it often means that there just hasn't been enough research done on that variant, period. We don't have enough information on it. We don't have enough to do this classification. So what can you do with it? Number one, I would recommend connecting with other healthcare providers and research groups, especially other providers that are working on specific conditions. I mentioned that I've literally gone through this process before of trying to find other patients with loss of function variants in the SHANK1 gene. That was my specific case. Gene Matcher is a great tool to utilize that. Gene Matcher I usually call like a dating app for variants or for genes where one person can put in one gene and another person can put in another gene that they're looking for more information on or more patients with. And then if 2 genes match, you'll get a match. And you'll get the emails of the other providers that are also looking for the same gene. So this is a way to find other providers who have said that I am looking for other patients with variants in a particular gene. In that way, you can compare and contrast. So say you have a VUS, I'll just use a very, very easy example, BRCA1. This is not a rare gene. Obviously, it's a very common gene. If you have a variant of unknown significance in BRCA1, it may be worth looking at Gene Matcher to see if you can find other people with the same exact variant. Although, to be very honest, I might stick to more rare genes. I think that for BRCA1, you would get so many answers back that maybe this is better used for a gene with a little bit less information. But that is a great way to connect with providers internationally. You can request a reanalysis. So VUSs will change over time, as I said, because VUSs are usually stemming from not enough information to be able to classify it. Eventually there will be enough information. Eventually there's more information on the gene. There are more public databases with more patients in them, with more genomic data, more biobanks over time. So we're able to see how this gene affects more people. Usually that's a way to be able to grade or classify it if the variant is seen in more people. And so over time, variants will be upgraded or downgraded from a variant of unknown significance to pathogenic or to benign. And so it is usually on the provider. It is the responsibility of the provider to go back to a lab and request a reanalysis over time. A lot of labs will do that yearly. So I would recommend keeping your VUSs, your variants of unknown significance, maybe in one folder on your computer and going back once a year and going back to the labs and asking if this variant has been upgraded or downgraded. I know that yeah, I know that labs usually will do a free reanalysis. All the labs that I've ever worked for will usually do a free reanalysis, at least one. Number 3, make every effort to include clinical information and parental samples. If you include all of the patient's clinical information to begin with, and you include parental samples when needed, for example, that would be for whole exome sequencing or whole genome sequencing, for example, you're much less likely to get VUSs in the first place. I have a very recent case. I'm now working in oncology at Natera, where we had a BRCA1 VUS. I suppose that's where I got that example from. And it was a VUS by our lab. It was called pathogenic by a couple of other labs. You can see just by this example that these standards and guidelines, even though it's an attempt at standardization, it can still be a little bit subjective how these things are classified. And so we were able, once the genetic counselor gave us the pedigree and the family history, because the same variant segregated in multiple affected family members, the variant of unknown significance, we actually upgraded to pathogenic after seeing the family history and the genetic testing reports of family members. So it's really important to provide all of the clinical information and family genetic testing information to be able to avoid getting VUSs and to have all of the information available to be able to make those calls, those classification calls. Most importantly, variants of unknown significance should not be used in clinical decision making. This is extremely important. A lot of providers who are unfamiliar with genetics will be confused by a variant of uncertain significance. They don't understand what it means clinically. Clinically, it means nothing. Clinically, you can't make a decision on a VUS, especially if you're thinking oncology and thinking you're going to be treating a patient or changing, potentially making surgical decisions based on a genetic family history, not based on a VUS. That's inappropriate because there's not enough information to know if it's disease causing. There's a stat also that I'll share with you that 9 out of 10 variants of unknown significance, at least in the oncology space, become benign, end up being reclassified as benign. So you definitely can't consider it something to make a clinical decision on. I found a paper when I was doing a little bit of research for this saying that variants of unknown significance may be gone by 2030. So it was an interesting article. I don't know if they'll all be gone by 2030, but I understand why they say that. Classification standards keep evolving. I'm using this original 2015 ACMG criteria because this is the backbone and the basis for all classification of labs that I know, at least of US and CLIA certified labs. But it does change over time. And, there have also been updates to that classification and updates to some of those criteria scores that I haven't mentioned here. De novo, for example, I think I presented it as a strong piece of evidence whether a variant is de novo. I think that there has been back and forth about that, and I think that de novo status may not be considered weighted quite as heavily anymore based on some of the updates that have come out over time. It also probably depends a little bit on the lab and again that subjectivity, but as we improve classification standards and unify, VUSs may decrease. Data sharing, the more data we have, the more information that we have in order to classify. So the more patients that we are able to get into these large, hundreds of thousands of people. There's the All of Us program that's trying to enroll 1 million people that's based in the US. This is the more that we know about what each variant does in different people with different backgrounds, the less likely there is to be variants of unknown significance. And precision medicine. This is the idea of precision medicine and being able to look at someone's genes and know the way that they will be treated based on that. If we keep doing that and keep doing these functional studies to understand how different genes work and how they affect the protein, we're less likely to have VUSs in the future. So to be determined on whether 2030 will bring us an absence of variants of unknown significance. But right now, it seems like the rate is decreasing based on some of these improvements in data sharing and classification. And that is what I have. Thank you.
That's a brilliant session, Halie. Thank you very much. And yeah, I just want to mention that you have indicated from the pathogenic classification, from very strongly classified to the supporting evidence of pathogenicity. And you have mentioned that from VUS to upgrade and downgrade. That's actually, we have to be in vigilance on that. Whenever, but in Indian scenario, or I don't know what's the scenario in there, but when compared to the Indian scenarios, we have a lot of variants. We have seen out of 10, more than 7, 8 patients, clients we have come across with the VUS variants. So it's a huge data. Yeah, it's a huge data of collecting VUS, and we have to be vigilant, as you mentioned, of upgrading and downgrading. And in an addition point, you mentioned that as you have seen that BRCA variant for VUS, and soon after that you have gone through the pedigree, then you got it that yeah, they have the particular variant is come across with the family. Yeah, and then you classified it as from VUS to pathogenicity. That's an incredible thing, and where we can say that particular pedigree and genetic counseling helps and excel in that particular case. And that's tremendous. And yeah, I think it's a fantastic session, and thank you for accepting. And your expertise in addressing the challenges and offering practical solutions that enrich our understanding to this complex topic. And now I'm opening for Q&A session. If any questions are there, kindly let me know in Q&A chat box. Halie, we're always open to discuss. Yeah.
Thank you. And I agree with that. I think that was a great learning experience for the provider to understand how important it is to provide all of the information. For that particular case, she hadn't originally sent in the genetic testing report for the affected family members. And it ended up, of course, that mattered so much, and that changed the classification from VUS to pathogenic. So it's just so important to include all of the information, and I've seen that in real world cases.
Yeah. I think a question from here from Deepak. Isn't a MDT discussion warranted to VUS that are just below the pathogenic scores?
Honestly, I don't know what MDT refers to.
Okay.
But thank you for the question.
Halie, let me, ask me one thing. So, with the increasing integration of AI and machine learning in genomic analysis, how do you foresee these technologies will influence the classification and management of VUS? What's your thoughts?
With the updates in technologies of genomic analysis?
Yeah. So how we can cope up with that, and how you can foresee that? Yeah.
I think that as genomic analysis becomes easier, becomes cheaper, and more people have access to it, I think the VUSs will decline. Like, for example, I can see a future in the next decade or so when babies, at least in the US, the UK, places like this where they have these huge biobank and whole genome studies, I can see babies being sequenced at the time of birth to see if they have any genetic variants that are impactful. We're already doing newborn screening, for example, in the US. So a lot of times it'll be metabolic disorders. It varies state by state, but metabolic disorders where there is treatment and management, if we know that the patient has this genetic change, there's a set of maybe 40 to 50 disorders that we're already testing for at birth. So I can totally see this either increasing to a panel of 200 to 300 genes right away when babies are born, or maybe even eventually whole genome sequencing. And the more that we have that data, if this is actually successfully shared and consistently curated in one place, I think that that'll just give us so much more insight into so much more people. And so for sure, as things become more accessible, the VUS rate will go down because we'll be able to see what variants more people have.
Got it. Understood. And yeah, in connectivity that, is there any specific tools or platforms that you find promising in improving it? Like you used anything like tools or softwares which actually, promising to assess VUS or any improvising the data of previous assessments or something like that?
Yeah, so I talked about GeneMatcher. I think GeneMatcher is a really important tool. GeneMatcher is a great way, especially for rare disease and rare genes, to connect with patients across the world. Decipher is another tool that I use, and that is, it's used for a similar way. It's used to see other patients that you can connect with that have variants in unknown disease genes, but it's based mostly on copy number variation. So CNVs you would want to use Decipher and instead of GeneMatcher maybe. And as far as, there's all of these automatic websites that you can use, databases that you can use, and you can put in a VUS and you can say what it'll come back with, what classification it thinks is correct. I like Franklin. There's Varzome. I think Franklin is very easy to read. It has a nice layout. I like the quality of the literature review on Franklin, so I would recommend Franklin if you're going to look at the classification of a variant on your own based on a computer algorithm. And then Nomad, of course. Nomad is, I think, still the largest control database out there. So if there's a variant that is a variant of unknown significance, if the data is not on the report, it usually is, you can manually check Nomad yourself to see how many other patients the variant has been seen. It'll tell you how many patients the variant has been seen in controls, the sex of the people. It'll tell you the background of the people, the ancestral background. It'll tell you whether it was seen heterozygous, homozygous, in cis or in trans. So I think Nomad is also a great resource to manually assess variants.
Agreed. Even I used Franklin a couple of times. It was phenomenal in doing that. Yeah. And we have a question from Aruna Priya. Thanks for the wonderful presentation. Considering multiple ethnicity populations, do you think these guidelines are universally applicable?
That's a good question. I think the guidelines are still applicable. I think there's just not enough database information out there for different ethnicities and backgrounds. Really, it's mostly European, Caucasian samples in these large control databases, even Nomad, for example. So I think the issue is not necessarily the guidelines. I think it's that there's not a lot of information out there on the genetic variation in non-European individuals. So I don't know that any guidelines would pick that up differently. I guess I haven't really done a lot of critical thinking on how the guidelines could be different to pick that up. But I think that mostly the issue is that there's not enough representation of those other ancestries in the databases.
Got it. And we have a question from Prasad. Having said about the reclassification of VUS to pathogenic, is there any pathogenic variant that is converted to VUS or non-pathogenic? Is there, if so, any case or example?
That's a really good question. It's very rare, and I honestly haven't worked with one myself. I've also, because I come from more of a research background, the cases that I've been involved in have always been more conservative. I think in research we took a more conservative approach. We were always hesitant to confirm or give back any variant if we weren't really sure that it was disease causing. And same with Natera, I think, where I work now. It tends to be a more conservative classification. Again, even that example that I gave, where this is top of my mind because it's a recent example where we classified this BRCA1 variant as a VUS, and other labs classified the same exact variant as likely pathogenic and pathogenic. Part of that, I think, is us just having a generally more conservative approach. So I think that the guidelines actually try to avoid overclassification of pathogenic variants, and I think it does a fair job at that.
Agreed. Yeah. And we have a question from Devika. So your opinion on how do you explain a BRCA, VUS in a EUS TNBC, that is triple negative breast cancer patient with no family history and a clinician thinking of giving PARP therapy, maybe PARP inhibitors, as patient has progressive disease after multiple lines of therapy. Also, how often do you request for reanalysis of this data?
So I don't think that therapy should change based on a VUS. So I don't think that PARP inhibitors should be given based on a variant of unknown significance, just based on a lot of what we talked about, that there's just not enough evidence to say that it's disease causing. I'm not an oncologist, so I can't speak to, I suppose if an oncologist wants to try a different therapy because they want to, they can, but based on the VUS, I would not, since clinical decisions shouldn't be made on that. For the same VUS, I would ask for a reanalysis in a year to see if it's been upgraded or downgraded, and I would do that on a yearly basis. I would reclassify or check VUSs on a yearly basis.
Got it. So how do you balance the ethical considerations of communications of VUS to patients whenever you're counseling the patients? So how do you balance this, the ethically and, while communicating and explaining about the VUS? So what are the challenges you are facing?
I really appreciate that question as well. I explain it to patients as a question mark. I say that we just don't know. I explain that, it doesn't mean it's negative. It doesn't mean it's positive. It means that we don't have enough information. And unfortunately, the field of genetics is fairly new still. And so we're just not going to know until we get more data and until a few years into the future. So I acknowledge that it's a frustrating result and, obviously try and listen to the patient's concerns, but I do stress to them that there's nothing that can be done about it and no decisions that can be made. And that although a frustrating answer, it is essentially still an unknown and negative result. But it's hard. It's very hard.
Yeah, the same phenomenon, same scenario in TEQ, but ultimately we have to explain. Yeah. And then we have a question. Thanks for the great presentation. What innovative methods are being used to prioritize which VUS should be revisited for potential reclassification?
Yeah, that's a good question as well. I wonder if it makes. I think it makes more sense to prioritize VUSs where the gene does seem like a good clinical fit, because that is one that's maybe a little bit more suspicious. Either if there's a good clinical fit with that gene, or certainly if it segregates in multiple family members, that would be a good reason to go back. I do think that's clinical judgment.
Yeah. That's why I think some people, as I said, that multidisciplinary team, whenever we are approaching with the clinicians or approaching with the, different departments, along with the, as you mentioned, with the segregation analysis with the family and having a cluster data with the pedigree and a broad family history, then we definitely go with the VUS in a precise way of finding, revisiting the analysis. That's a great thing. I hope that there are no more questions from the audience. So on behalf of everyone here, we extend our heartfelt thanks for sharing your valuable knowledge and for leading this such an engaging session. Thank you, Halie, for coming and expressing your views, thoughts, and your expertise. That actually matters a lot. And I know it's a 6 a.m. there. Definitely, you went and gone through with all the presentations. And thank you very much. Thank you so much. And I just want to convey the thanks to the audience too. Within a single day, a lot of people, more than 60, 70 people, are joined, and it's been engaging questions. And it's really matters. Thank you, everyone, and thank you, Halie, for joining, making
Thank
this.
you.
Yeah.
Thank you, everybody. Have a great weekend. Thank you for being here.
Thank you, Halie.